Well, thank you so much, everybody. It's so great to have everyone here taking the time out of busy days and workload schedules to spend time with us this afternoon. My name is James Carter. I'm one of the heads of clinical programmes for NHS England Improvement in the South East. And I hope that today is going to be useful from both a learning and a sharing perspective, but also generative and thought-provoking. If we can go, Naz, to the housekeeping slide, please. Just so you know, and I'm sure everyone is, Teams users par excellence nowadays after 2 years of working in these environments. We just want to let you know that we're asking colleagues, please to, please to go on mute, and we will be recording this session. So especially if you're happy, as long as you're happy with that, then we're good to go. Naz, that's okay. Thank you. On what we would like this to be is that we have a number of colleagues here today, esteemed colleagues and colleagues who have worked in this space for a long time from an NHS perspective, as well as academia. So what we would like to do is maintain the speakers to have their mics open during that time. So if you're happy, please keep yourselves on mute as much as possible. We are encouraging some questions and reflections. That can be achieved by the chat function, which you can see. Hopefully, this is very self-explanatory on this slide. Yes, please do add in your questions and reflections. We haven't planned for a Q&A at this stage. However, I will be guided by Etta and others if that seems sort of pertinent, and we will try and pick up the reflections as well to try and feed that back in from the conversations. Yes, so and also if you do have problems with your bandwidth, which isn't necessarily a phrase I didn't think I needed to say out loud up until about 2 years ago, then please switch off your cameras. We won't be offended too much by that. So that's great. On to the next slide, please, Naz. Thanks. Yes, so having spent the past year in the gambling harm space, I've been amazed at the multifaceted nature of this agenda, the actors, involved in all areas across political, clinical, commercial, and more importantly, societal. Because we know that while people can gamble without issue, there are also those that are at an increased risk of disordered gambling, and the potential harm that is associated with this is vast, it's widespread. It's multifactorial as well, and that is often characterized as needing a public health approach, which is similar to other sort of societal and multifactorial issues such as alcohol, domestic violence, and so on. And I just wanted to recognise really in this slide the excellent work that's gone on within the public health narrative, as well as the long-term work that's come out of both Houses of Parliament. And attached to this slide and also going into the chat are some excellent resources which are worth a bookmark if you haven't already utilised them, which I'm sure you have. So yeah, please do take the time to look through that. All things being equal, I'd love to support a continuation or this being a part of a wider stakeholder engagement piece, which drills down more into these public health imperatives. Alongside OHID, the new Public Health England, the Office for Health Inequalities, and others. So, that's really just wanted to sort of make a note of that, because whilst we are here to talk about the NHS approaches, we are going to be also recognising that there are many, many factors involved. Thanks, Naz. Next slide, please. So why are we here today? The long-term plan, and I'll let Etta sort of take up a larger portion of this, has committed to establish 15 NHS gambling harm clinics nationally by 2023-24. And in this coming year, we are looking at 2 new clinics taking root, one in the southeast, which is the area that I'm sort of focused in at the moment, which is down in Southampton, as you can see on the map here, and then one in the West Midlands, who are going to join those services that are already established in London and parts of the North. And we're fortunate to have colleagues from both of those established services here to talk today. We also know the importance of identifying individuals with problem gambling is crucial for the NHS to provide services, and a major avenue for most people is through their local GP services. Naz, if you can go to the next slide. Again, I'm so pleased that we're able to welcome Dame Professor Claire Gerarda to offer her reflections on the potential of primary care and gambling harm. And it's also important that we understand the experiences of family members, loved ones and those who have experienced disordered gambling in their own lives. And I'm delighted to welcome Jim Orford from Birmingham University, as well as Stacey and Nick, to leave us with some excellent reflections on lived experience and, you know, potential utilisations in a new social media world. So, without further ado, I would like to invite Henrietta, Professor Henrietta Bowden-Jones, who to give us much more of a reflection on the past and also the future. She's been a vanguard of the gambling disorder conversation for many a year, and has lit the way for so many of us as well. So over to you, Etta, and thank you.
Thank you so much, James. Can everyone hear me okay?
Yeah.
Great. I won't use a slide. I decided to make a speech. I don't often make speeches, but it does feel like it's a very much of a historical moment, and I'd like to mark it with a few thank yous and a few brief summaries pointing out some of the big players over the last 15 years. My dear colleagues, I welcome you today to an NHS meeting that only a few years ago would have been a dream, a pure fantasy of mind. For the past 15 years, since deciding to set up the first NHS clinic for gambling disorders, I've been navigating the world of knowledge and evidence base in this field, relying heavily on my international colleagues. Some today need to be acknowledged and thanked. Mark Potenza, above all, as the most constant presence in my life during those early years, receiving texts and emails at all times of the day and night with urgent questions about the management needs of patients, the treatment protocols, the team compositions, and many more topics. He tirelessly answered them, and at international meetings provided me with the support I needed to continue forging ahead, despite the many obstacles. The late Nancy Petrie, to whom our new Cambridge University Press book on gambling treatment is dedicated, is coming out any moment, so watch out for it, was the go-to person for the treatment and research. Her textbook became a Bible to me, and I relied on it heavily throughout the first 3 years of setting up the clinic. At a time when no one, and I mean no one, in my professional cohort was interested in gambling, and even less in gambling disorder, at a time when people would avoid sitting next to me at conferences, joking that they had heard enough about gambling, there were international colleagues offering strength and support. I was a leader. I had a clinic to lead, but I was alone in a country where gambling disorder had not been taught to me, despite my training in addiction psychiatry, despite the many years at the Chelsea and Westminster Hospital, the years at the Charing Cross and St Mary's training rotations. Henry Ladouceur and Jeff Derowensky, Alex Blazinski and Joanna Franklin were my reference points. I will forevermore be grateful for their generosity of time and of intellect. They led by example. And years later, when I myself could be considered an expert, it was their generosity with international and younger colleagues that led me to say yes to so many from all over the world who have joined us at the National Problem Gambling Clinic for their training. From Japan to Spain, from Portugal to South Korea, we've had the whole world come through our rooms and join our team meetings and learn from us and from our patients. When I look back on the many faces of colleagues I have trained, I feel blessed by the energy and enthusiasm of the 250 plus people who have worked with us at CNWL in the gambling clinic. Many have stayed in touch. The expression "a big family" could not be more apt. My thanks also to the thousands and thousands of patients we have treated. We helped them, they helped us understand how destructive and severe a disease gambling disorder truly is. In recent years in particular, the arrival of Becky Harris as the manager of the clinic added enormous strength and capacity to our work and drove much of the future expansion, as it allowed me the time to focus on the bigger picture. When we started, and for several years, I did every single assessment of every single patient referred to our clinic. My thanks to go to Becky for all of the above. Without her, we would not be where we are today. 4 more people are key and need my thanks today. Claire Murdoch, our CEO at CNWL and NHS England lead for mental health, who has supported my vision for the past 2 decades. Lord Chadlington, whose ability to turn a dream into a reality changed my life forever when he brought not 1, but 2 health secretaries into the clinic in Earl's Court. By the time Jeremy Hunt and later Matt Hancock sat down with me for those initial discussions, I knew there was no going back. We needed to fight for change, and this we did. The subsequent work with NHS England on the 2019 long-term plan expansion, and the reason why you're all sitting here today with a final plan of 15 clinics across the country, would never have happened without Lord Chadlington's intervention. And for this, I will eternally be grateful. Lastly, the expansion of the number of clinics led to an initial new colleague, Matt Gaskell, whose brilliance and relentless pursuit of justice has made him stand out as a leading figure in this field in his own right. Matt is a born leader. He has fought for all we have achieved, and to him I am also in debt. His current leadership on the NICE Guidelines Committee is only one of the many strengths he brings to the gambling field. Finally, a few words about the wonderful colleague at NHS England and colleagues at the HSC who have helped us lead the way into a new era for the treatment of gambling harm. The process was exhausting, but the teamwork was superb. For this, I am truly grateful. Alex Mahaffey deserves a special mention. She has put all of her professional and personal drive into taking this expansion across the finish line. Thank you, Alex. I'd like to welcome our new colleagues today as we prepare for what will be the post-gambling review era. Whatever it will bring, we will be there to face it together. Many changes will be necessary, but I know we will face them together and will work with a shared common goal of fighting gambling harm in England for our patients, for their families, and for the population as a whole. Thank you to all of you who have done up to now. Thank you to you all for all you've done up to now and for all you will do. I will be there to support and to guide you. Thank you.
Etta, thank you so much. That's a fantastic start to this meeting, and we can sense just from your takes there and people reacting on the screen as well that you know, we can tell how much your life and your professional commitments has taken to this, and you know, also how important having people alongside you and learning from has been important as well. So thank you. That's been quite an emotional and also very eye-opening insight into how much of a commitment this has taken to bring this agenda forward. Would you have a couple of minutes just for me to ask a couple of questions, or just to get some sort of further reflections?
Sure, absolutely.
Great. Well, what's interesting is the work that you led clinically has led us and brought us to this point, and thank you for referencing Alex and Becky and Matt, who have been involved in that sort of extension and expansion. Can you just talk us through the interface with the Houses of Parliament and, you know, in regards to the gambling harm reviews that have been undertaken, and really what the step changes might have been in respect of, either potential for treatment or understanding prevalence, and what those studies have really tried to sort of bring out, and what you've seen as a development.
Sure. So I truly believe that it was the joined up work of having an APPG on gambling harm pushing so hard in conjunction with people like Gambling with Lives, who were breaking down barriers that none of us had dared break down, because obviously at times they were uncomfortable to many. And people like Liz and Charles do deserve a mention here, because I think at times they led the way and we followed. In a way, Carolyn Harris too, Ian Duncan Smith, there are just Ronnie Cowan, people who were not afraid to say it as it was. And this opened up a conversation, partly, you're right, whether it was the House of Lords meetings or the House of Commons meetings. Much of that work was very important in the early days, because that's what really shifted things. But also on social media, the involvement of experts by experience was vital. And I truly believe that none of this would have happened without experts by experience and all their commitment and their fearless, literally their fearless fighting for justice. The groups that have formed, and there are many now. Of course, we live in a different world than we were in, 15 years ago, when there were a few who had a voice. Now there are many voices. There are voices of families, there are voices of people who've lived the illness, and I think we can truly rely on them to let us know what still needs to happen. And I hope the Gambling Review will have really taken notice, because they work so hard to feed back what needed to change. I'd like to mention Matt Zarb-Cousins as well, because actually he has been a real star, and again fearlessly has pushed for justice and continues to do so on a daily basis in relation to gambling harm. So I think that what happened is that there was a beautiful coming together of what the APPGs, the House of Lords. Remember, the House of Lords has had more than one group representing the need to change. So the latest incarnation is a Peers for Gambling Reform with over 250 peers. It just gives you an understanding of what justice means in the House of Lords and how vital they feel it is as an issue, gambling harm is. But certainly what I realized, having come through the whole journey, was that everyone, probably the culmination being at the ministers at Chris Philps' round table, when 15 experts all said, we need a 1% levy. We need independence of the NHS from any industry funding, and so on and so on. And the fact we all came together on these, on the advice to government, and whether they take it or not remains to be seen, I very much hope so, is an indication of what great work took place. And all the people I've mentioned were really key, plus many more I haven't mentioned.
Sure. Thank you for that. And of course, we've got a white paper due into this year, haven't we, Etta? So that's also part of that sort of discussion, and hopefully a culmination of the work that's been involved. And finally, just for the next couple of minutes before we invite Claire to speak, the ambitions for the NHS in regards to gambling disorder and treatment. Not only are we talking about building sort of stronger services and services that are able to to support people with gambling issues. Can you talk to us a little bit about sort of the research and the not only the treatment side, but what else sort of captures there really from the ambitions?
We are in a position now, James, where we can not only make sure we provide independent NHS-led treatment, And of course, we do need the seamless collaboration with our partners all over the country. This isn't just an NHS working in isolation. But most importantly, and what has been missing really, is a significant piece of work using scientific knowledge, using research to back the treatment. So at the moment, we do have the NICE guidelines working committee that will address some of the recommendations of what the best gold standard treatments should be, so that we all know, are we doing the best we can for all the patients in this country? But the second thing we need to realize is that many of the studies that NICE will include may have been conducted in Australia, in America. The people they will have been treating may have been gambling on different products. They may not be the same group of people with the same demographics. So we have a duty as a NHS system now to record and share protocols. We need to collect the same information, and we need to follow up our patients. This is something that's been direly missing, and we cannot justify spending NHS money unless we are very clear that we are spending it in a way that is helpful to the patients and to the country as a whole, because as you know, there is an enormous financial impact from gambling harm to the country, not just to the people involved and their families. So I want to see outcome measures being a key player now. And when we have our meetings for the group, as we will do every month now, the key priorities will be absolutely, let's get these outcome measures sorted. 1 year, 3 years, 5 years. Are these people who we've treated gambling again, or have they truly stopped? Have we helped them enough? Do we need to add something to our treatment? So I think the outcomes is a big problem. It's not a problem, but it's something we need to do. And I'll add one more thing that is vital, and I know many on this call will agree. At the moment, we don't know what happens to all the thousands of people who call that helpline. Okay, there is a helpline, but we don't have enough information about how are they assessed. What severity are they presenting with? What are their problems? And how are they apportioned to treatment? What's happening to the suicidal people who are calling that helpline? I feel that it's a responsibility of the NHS to take care of those patients and make sure that they end up in the right part of the system, be it NHS, be it non-stat agencies. I'm not in any way suggesting the NHS needs, thousands more people, but I'm saying there will be people there who need to attend NHS systems because their presentation is severe. So I think there's going to be quite a big revolutionary approach to how do we collect the need of people across the country, how are they presenting, what with, and we need an evidence-based, very clear pathway for them. I'll stop here because I could talk all day.
Not at all, Etta, and these are important factors. And I take your point that we've got to sort of be, slightly sensitive in respect of how we're addressing that. But there is a continuum, and therefore there are opportunities there. And I think there are people sort of up for that challenge. And like you say, it might not be the NHS, it could be other services. But it's ultimately about how you build that sort of recovery sort of knowledge or treatment sort of knowledge base, I think is really important. So, just a brief point from me, Etta, we've known each other sort of in a very short period of time over the past, over the past six or 9 months. Your commitment shines through, and the levels of engagement that you have brought about through, dare I say it, sort of sheer bloody mindedness, as well as the absolute skill and knowledge and abilities that you have as a clinician and as a person are really very important to everyone. I'm sure your thanks to all of those colleagues and to those individuals that you've helped through the years, as well as those that you didn't necessarily mention but are all part of that, would certainly reciprocate their support and gratitude to you. So thank you, Etta, and thank you for your sort of commitment to me, really, to say that you would be interested in leading and helping us sort of bring a group together that is, NHS focused, but also recognising the much more wider picture as well. So thank you, Etta, and I'm sure you'll come back on if you need to, and please do sort of put some thoughts in the chat if you would like to, as a result of any of the other conversations. Thank you, Etta.
Thank you.
Brilliant. Well, guys, I wasn't necessarily expecting that from Etta. I knew that we were going to be hearing from her, so it was really interesting to hear her take, and obviously to hear the amount of time and commitment she has spent in this space. A similar individual who is a very renowned individual, as well as an esteemed individual and colleague, is Dame Professor Claire Gerarda. You will know her as the chair of the RCGP currently, as well as being a huge advocate in the addiction space, as well as being a really strong advocate and supporter of clinician-based health as well. And from your experiences, Claire, it'd be really interesting to hear not only how you see addiction within primary care. Of course, please tell us as much as you can in those areas, but perhaps something about the primary care network role as well might be interesting as we talk about sort of integration, if you will, as the much bigger piece. But over to you,
Thank you.
For your reflections, and we're really looking forward to hear from you. Thank you, Claire.
Thank you. And first thing is, can you hear me? That's always the thing. Yes. Can you hear me?
We've got you. Yeah, we've got you, Claire.
Okay. First of all, thanks to Etta, because it's through Etta's leadership that I'm here, really. So I'm going to talk about primary care gambling service. And whilst I'm very, very pleased about the plan to open a number of gambling hubs across the country, unless you involve primary care, they will rapidly silt up. And also you won't get the patient flow through. And don't make the errors that were made in substance misuse many moons ago, which is where I come from, which is an addiction background, but from drugs, really. And just like Etta, even though I did psychiatry training and addiction training, I learned nothing about gambling, to be absolutely honest, till recently. So I'm going to talk really briefly about my service, primary care gambling service, which is new, and it attempts to bridge the gap between the specialist services such as Etta's and the primary care and voluntary sector at the other end. And it aims to encourage patients and people, carers, significant others to come into treatment. It also aims to empower GPs and the other members of the primary healthcare team, including the new breed of clinicians that we've got, physician associates, pharmacists, social prescribers, all the sorts of different panoply of people in primary care, to make them and to understand and empower them to recognise that gambling can be a gambling disorder, because I think many people still out there think it's something that you play on the internet and it isn't an illness, and if it is, it's nothing you can do about it. So I run a multidisciplinary team. It's a GP-led primary healthcare team that has psychiatrists, nurses, therapists, managers within a single setting, a single budget, where, as I said, we sit between the voluntary sector and the specialist sector. Now, despite the pandemic, in the last 12 months, we've had nearly 100 patients presenting to us and a small number of affected others. And they come predominantly at the moment from the gambling helpline, from GamCare, but we're also getting them now directly from GPs. We're getting them from something called eConsult, which is a digital consultation, which is available to about 22 million people have access to it. And we've put a question on there. You consult with your GP, you can say consult about acne, but we've put a question on there under the smoking and alcohol. Do you also have problems with gambling? I haven't quite phrased it like that, but you'll understand. So we've had numbers coming through, and the numbers as we speak are increasing. So obviously we're getting traction, and we're on social media and we're getting traction. And we do act as an intermediate. So we have referred patients on through the system. So we have step up, step down, predominantly to Gordon Moody, a few to Etta's service, but the rest of them, so the vast majority of patients, we work in partnership with the voluntary sector with therapists and with GPs. So the patients sit within our service. We manage them with a whole range of therapies, ranging from art therapy, group therapy, individual psychotherapy to cognitive behavioural therapy, you name it, and including a limited amount of prescribing, but we can prescribe, and we've just started to prescribe naltrexone. So we are there. Now, the important message is that we don't replace secondary care. We are absolutely not replacing, but we're an adjunct to it. And we aim to engage the whole system within our patients, so that the patients, if you like, have all of their needs. And if there's one thing I've learned from managing these patients, is that only about 5% have a purely gambling issue. The rest of them have a range of problems: learning difficulties, psychosis, depression, comorbid cross addictions, physical health problems, and housing problems. And as a generalist service, which is what we are, we have the skills to be able to manage these patients, because we do understand very intimately the other services that are available, either alone or linking in with, as I said, primary, secondary care, primary voluntary sector. Now, every patient that comes through has a personalised care plan, which might involve them having a number of therapies, or we provide, as I said, a personalised. So the plan that we have depends on their health, social needs, and other needs. And we assertively follow patients up. So we don't assume a do not attend means they don't attend. We do our best to engage them and be music to Etta's ears. We do have we use the PGSI, we use Core 10 and a new questionnaire called Cyclops, which is actually a patient reported outcome measure, which is actually a lot better. So if the patient outcome wants to be, well, I want to have enough money to buy a christening present for my daughter who's having a baby, that is the outcome that we measure on, rather than the artificial outcomes that we have if they're not patient reported. And we have an active tracker where we record from the start of the patient presenting it to us right through to the end of treatment, a whole range of factors such as demographics, occupation, ethnicity, comorbid issues, questionnaires, previous suicide, and others. And importantly, we monitor at start of treatment, 3 months, 6 months, and end of treatment our outcomes. So we are an outcome-based service, and we're very, very, very pleased that we have excellent outcomes. And also, I'd like to just add, finally, the last few things, it's not just, I'm sitting here in the Royal College of General Practitioners, and I'm actually the president, not the chair, but that doesn't matter. And for the first time ever, the Royal College of GPs has a gambling lead, who happens to be me. But we've developed a competency framework. So Emma Ryan and Sharon Fernandez, who I know are on this call, have worked with me on developing this. And this competency framework will directly lead to the RCGP, which is a membership of the Royal College of General Practitioners exam, be in their curriculum. So even though the students and the trainees might not be examined on gambling, the very fact that it's in the curriculum will mean that they have to revise it. So it's not just about increasing the numbers going through treatment. It's about engaging the rest of the system that makes it feel as if it's their responsibility to be engaged as well. I'm not asking my profession to manage gambling disorder. What I'm just asking them to do is to recognise when somebody has a gambling disorder, or when somebody is at risk of gambling disorder, and to appropriately direct them into the right service. So my vision, building on Etta's vision, is that with these gambling hubs, that you actually think very carefully about making sure that they are multidisciplinary, that they do not involve primary care, because if you do, then I think you're going to miss a trick. And if the prevalence of gambling is as high as we think it is, you will rapidly silt up, and they will go nowhere. When HIV started and patients with HIV infection were only managed in specialist clinics, we learnt our lesson, because these patients still needed their medication, still had other comorbid conditions, still needed sick notes, and you cannot rely, well, maybe you can, but you'd have to that would take significant funding. So really, that's what I'd like to just end on by saying. Wonderful work that Etta's done, wonderful work that the National Gambling Service has done. I feel that we're the new kid on the block as the intermediate service that's acting as a bridge between the voluntary sector, primary care, and the specialist sector. We're easily accessible. We have virtually no exclusion criteria, and we're able to deal with the multiple problems that our patients present. And I really, really enjoy these group of patients. They are an extraordinary group of patients that personally I find very sad that people can spend so much money and time on their addiction, but actually when they make a recovery, when they have a recovery, it's an amazing achievement to witness, and they're some of the most extraordinary patients that I've managed ever in my professional life. So thank you very much.
Thank you, Claire. Fantastic summary there, and also, you know, the plea that you're making at the end there. You know, the systematic approach, but also the need for a connective sort of tissue, really, of what primary care can provide, I think is really important. Would you have a couple of minutes just for me to throw a couple of questions or some further reflections?
Of course, and also James, I think there's a few in the chat box.
Oh, great, yes.
So, I mean, there's one about
encouraging. While I look at those, Claire, would you just want to trail your bits on that are on the screen as well? Say
it again.
Do you want to trail your links on the screen in regards to the work that you're doing with colleagues, with
Doctors in Distress? Well, I'd love to. I didn't realise that slide was coming up, but well, that's a nice plug. So Doctors in Distress is a charity for all health professionals to prevent suicide, and we've got a conference coming up in 2 weeks' time. Anybody would be welcome to come. We're actually, to be absolutely honest, not talking about gambling at the conference, but I'm sure that you'll be most welcome to come. But thank you very much.
Thanks, Claire. No, that's great, and it looks a fantastic conference as well, and also is virtual as well as on in person. So that's great.
There are subsidised places, so if anybody really can't afford it, just ask, just shout out.
Sure. So yeah, an interesting point from Joe. Martin, I can also see your question there, and perhaps if Matt or others might want to just comment on you know, a little bit of a holding statement on Martin's point, but on Joe's point, and I think this talks a lot to, you know, to Claire's general sort of ideas here, whether we should be encouraging all GP practices to play a role in relation to gambling harm, so that patients can be held locally. And as you rightly mentioned, Claire, near the end there, you know your service users, you know your population. I mean, what's the opportunity, Claire? Have you had many conversations with primary care colleagues about the potential of this sort of interstitial sort of role between secondary and the voluntary sector with primary care as the hub? Have you had interest, conversations? Are people asking you whether you might be in a position to share elements such as the framework or the outcome measures and so on?
Yeah, absolutely. I mean, my sense is that until you know the true prevalence of gambling, I don't think, and just for listeners and people on this call, currently general practice is organised at a practice level, which is say an average list size of 10,000, and what's then called a primary care network level, which is a list size of about 50,000, and then a federation, which might be up to 200, 300,000 population level. And what I would be suggesting is that every GP needs to understand about gambling to some extent, and even that it's a treatable disorder, okay, but they don't need to know how to manage it. What they need to be able to do is to refer to an intermediate service such as mine. And I don't think I mean, we're covering the whole of London, so I think you probably only need one per region at the moment, unless you find that you have the prevalence escalates post-pandemic, and of course linked to the specialist service, because we cannot exist without a specialist service. But my caution is that a specialist service, it will be quite specialist and will be remote from, if you like, the primary care. So I think every GP needs to know how to identify a gambling disorder or somebody at risk, and that every federation, if you like, at a population level needs to have a service similar to mine, led through either a specialist or through a GP with special interest. But whatever it is, it has to be easily accessible with virtually no exclusion criteria, that's able to manage the multiplicity of the patients that we see. And we are receiving social prescribers. Thank you, Sharon, because a social prescriber is again a new kid on the block. It's somebody that's not usually medically or clinically trained, but is able to hold the client, the patient, and actually nudge them towards other services, or just hold their hand metaphorically as they sort out their housing issues. And a lot of people, as you know, with other problems, may well have an underlying gambling disorder. So they'll be able to identify those patients.
Yes, quite. Sorry, I realised I thought I was on mute, so there might have been some banging there. I apologise. Claire, yeah, no, that's really helpful. And you're right, the social prescriber route is something that is very much considered, especially within mental health. Not only from sort of understanding the neighbourhood assets, but also much more sort of realising that there are those sort of wider determinants as well at play. You also mentioned some of the newer roles like the physician associates and community prescribers.
The pharmacists, yes, and the
yes, that's right, the pharmacists. And is there any sort of role from a nursing perspective that you are obviously in a privileged position, and I do apologise for misrolling you, within RCGP, within the RCN or within other sort of, other colleges that potentially this sort of messaging could be heard?
But let's not make the errors we make with drugs. I don't think that all GPs and all nurses can manage patients with a gambling disorder. Number one, we don't have the time. We don't have the resources. It's a real difficult thing. So I've already said we've used a whole range of treatments, right from art therapy through to behavioural therapy. You couldn't expect your average GP to be able to understand that complexity. The future has to be intermediate services that sit between primary and specialist. It has to be that I know I can pick up the phone to Etta and her service. Your average GP won't. And also, I don't suppose she'll want the phone for 4,000 GPs to ring her up, but she might want for 1 or 2 to ring her up to ask her advice. So I think that's the future. But the other beauty that we've got about being primary care is we understand the system. So we've got it onto the electronic medical record system, the EMIS system, and there are others. It's been hard work. But it means that there'll be pop-ups. So, for example, if you present and your code is of having domestic violence, then that will pop up, have you thought of gambling? Depression. Now, we're working hard on this. We haven't yet sorted it because of the technicalities of the providers of these systems, but it's the way to start sorting it. So the future has to be learn from the past, learn what failed in the past and build on the future, but don't expect the primary care to be doing. Our competency framework, by the way, James, covers nurses, covers social prescribers, and covers anybody that works in a primary care setting, because it's not specific to the designation of your specialty, it's specific to the level of competency, which is again, we should start.
Okay, everybody. So thank you for coming back. And I hope that that's been a helpful slug of time there with Etta and with Claire. I'm really grateful that so many people have attended today. I know how busy everyone is. We felt as though it's a really important time, not only with the expansion of the clinics, which is an important factor from an NHS perspective, but I'd really like us to just try and sort of go into a little bit more detail through Dr. Matt Gaskell, who runs our northern the northern clinics as part of the NHS programme. We're then going to move on to Jim. Jim will be talking us through the evidence and work being undertaken to support affected family members, loved ones, and carers, which again is another important factor and talks to that multifactorial bit. And then we'll hear from Stacey and Nick as well from the lived experience perspective. So yeah, let's crack on. Matt, over to you. And as you go through the slides, just give Naz a nudge. That'd be great.
Thanks, James. Good afternoon, everyone. It's great to be here. Great to share a platform with such a great group of people, and also to have lived experience on the call as well, and contributing is great to see. Thanks to Etta for her kind words earlier on. She may or may not remember that I visited her clinic over the years, going back many years. I visited her at Soho. I remember going to Fulham. I remember going to Earl's Court. As I built up my knowledge and was looking for cash for the North, for the NHS to deliver gambling treatment. So I'm indebted to her, not just in the past over those years, but over the last 2 or 3 years where we've worked so closely together, and we've achieved a lot, and we've still got more ahead of us, working together with a whole variety of colleagues that she mentioned as well. So whilst the context is the expansion of the NHS clinics, there's no substitute for effective laws, effective regulation and evidence-based prevention activities. We can't treat our way out of, the gambling harm that we're seeing across society, but clearly there are people that need us. But I just thought I would always sit any conversations about treatment in the context of a comprehensive public health framework that's needed and effective laws in this space. So this talk, I'm coming at it from a clinical perspective, with a few observations that I've noticed and just where the new clinics might sit within a wider system of care. The main call really here is that the clinics shouldn't sit in isolation, and can't sit in isolation for many important reasons. So a bit of context here that just before we go to this slide, we've got an OHID group. So this is, as James was saying at the beginning, this is the new Public Health England body. There's a group looking at treatment pathways that will provide interim guidance by the end of this year that will support the work of the NHS and the NHS clinics. There's also the NICE guidelines that just got underway. That'll be about a 2-year process, which again will not just focus on evidence-based treatment, as Etta rightly said, but also it will have provide guidance on an evidence-based system of care for gamblers as well, which is really important. There's also a consultation underway by the National Gambling Treatment System on treatment pathways as well. So anything I've got to say about that here is really just to start the conversation, and it will all be usurped by those by all those guidelines. Important to say that gamblers are not a homogenous group. It's one of the most important things to learn about this population. So whenever you hear about one approach or one thing working, we really need to appreciate that this is a very diverse population with diverse needs, and we need a system to accommodate that truth. So I think we need what's termed an all harms approach to gambling, the accurate identification of gambling related harm on a continuum of harm basis, and to embed this group into a wider system of integrated care. So next slide, please, Nez. In terms of identification, we've got a real problem on our hand, but reframing that, a great opportunity now with the clinics to have our partners and our national colleagues support us to identify gambling harm. Only 2 to 3% of those who are seriously harmed by gambling come forward for support. Nearly all of those are self-referrals, indicating that gambling is not embedded into the areas where we could be identifying these problems. Nationally, we're not very good at identifying and intervening early. Usually people are coming in very desperate straits. They've tried repeatedly to get the better of their problems themselves, usually by the time it comes to coming for support. So we need to better identify and have earlier intervention built into the system, and obviously alcohol is quite a good model to develop from. It's also worth noting, not unlike other addictions, but gamblers often feel embarrassed and ashamed, and stigma really pervades this space and is a real barrier for people to come forward. So again, nationally, we need to do something about this. We're improving the way in which we think about mental health, and it's becoming much more normalized to talk about our distress and come forward if we need help. I think we're still quite a way when it comes to problems that are related to addiction and these sorts of behaviours. And the framing of that the industry have around personal responsibility probably doesn't help with that endeavour. So gamblers are likely to use some of the services that are on the screen there for related problems, but not necessarily, in a sense, putting their hand up to say, I've got a problem with gambling. So it's really important for our partners and colleagues across the health and social care ecosystem and the charitable sector to help by asking questions about gambling, as they would routinely, perhaps for smoking and alcohol and drugs. Gambling has a particular way of remaining secretive and hidden. It's quite difficult to hide an alcohol or a drug problem. It's extraordinary the lengths that some gamblers can go to in order to keep their gambling problem hidden. So it's incumbent on all of us to ask these questions and make them part of routine practice. And I think perhaps, you know, an example is primary care, and it was an excellent talk from Claire earlier on. Not necessarily going to go to their GP, although some do, asking for help related to gambling, but other problems may sit behind the gambling problem. So we need to be curious in our work and also make sure we have these questions that we're asking routinely at assessment. The other thing as well, I'm sure Jim will say more about this later, is we also need to ask if they're affected by somebody else's gambling problem. The effect on loved ones, family members, colleagues can be very, very significant. Okay, next slide, please, Naz. So from a clinical perspective, the population have some needs that these clinics can't meet and won't be able to meet. So it's important that the long-term plan transformation ambition of the gambling treatment clinics are played into conversations about integrated care systems. The benefit of a gambling treatment pathway will contribute to many areas, including health inequalities, working with the voluntary sector and primary care networks, as well as provider collaboratives. NHS treatment should be part of a wider population health approach. And what we know from the work that we do in the clinics and from the evidence base and the literature over the years is that gamblers come with other difficulties and other needs as well. So not only can those partners help in identifying problems, but they can also work within an integrated care model and with the clinics to provide the wider needs that these service users need. And often these other needs can be a real threat to sustained recovery. So it's really important, it's self-defeating for us in the clinics and in the NHS to be working on the gambling problems and discharge them. For many, they will need other needs met, and if they're not met alongside us, then that will be could present as a direct threat to their recovery. Next slide, please. So we talked about gambling harm lying on a continuum of severity, and this is one depiction of a reflection of that, and where we might have, you know, recreational gambling at one end and people becoming at risk and experiencing low to moderate levels of harm, all the way up to the sharper end that the NHS are involved in, where you get common comorbidities as well as gambling disorder, but also a system which includes approaches which are going to facilitate sustained recovery. So that it's not uncommon for people to have relapses, which can be devastating. They can be a suicide risk. So I think the NHS also needs to sit within an ecosystem of support which connects those people who need it to sustained recovery interventions. And I think it's likely that the charitable sector are going to perhaps play the most significant role there, and perhaps at the low to moderate harm level as well. So yeah, so I think Accurate identification and screening should lead to the most effective intervention, from providing information to brief interventions, to the work of the charitable sector, the mobilising the work of peer support, which has been really underplayed in this space, and they've got a great contribution to make. The specialist clinics dealing with gambling disorder and comorbidity. And we've obviously got rehab as well to think about for those service users that need a different kind of intervention. And as I say, a system that connects to sustained recovery and relapse prevention initiatives that really build individuals' recovery capital and helps them to reconnect with a life worth living. Next slide, please. So as I said at the outset, it's not a homogeneous population, and there's research of over 50 years duration looking at sort of subtyping the treatment population. And there are 3 pathways broadly that literature has focused on, and I've added a 4th here, which I'll explain in a second. So the top 3 there are broadly the 3 groups of service users that we see in the clinics. Categories are never perfect, and sitting behind these pathways obviously are real lives and a variety of different needs. So I'll just mention these briefly. The first one, known as the behaviourally conditioned group, generally these are individuals who don't report background or developmental difficulties, would talk to me and say, you know, I don't know how I've ended up like this. I had a good upbringing, good parents, popular at school, etc., etc. No mental health problems, and their presentation is all explained by gambling and the devastation that gambling can cause. So yes, this group are distressed. They'll present with anxiety problems, depression, suicidal ideation, if not suicidal acts, and so on. So it's still a very serious group. It's just that the traditional comorbidities don't come with that group. So yes, to the layperson, they might look like they've got lots of comorbidities, but they're all explained by gambling disorder and the consequences of living with a gambling disorder over a prolonged period of time. And it's really effective to treat that group with the gold standard evidence-based treatment, which is CBT. That does, usually does a really good job with that group if done well. The second group, which is our most common group certainly in the northern clinics, we have about 35% in the top group. Probably say about 50% of the second group, if not more. So this group have been termed the emotionally vulnerable group. So they'll generally describe much more developmental disturbance and difficulties from childhood, perhaps with caregiving and relationships growing up, difficulties managing emotions, perhaps with low mood, anxiety. There might be some trauma in the background, and they come to the gambling experience and gambling space where they're really reinforced by gambling activities, because it helps focus their minds, it takes them away from their problems, helps them to escape, helps them to focus their attention in an immersive environment for prolonged periods of time, and they can feel, to them, in control and normal and able to function. So this group, and obviously the NICE guidelines are going to assist us with all of these pathways. The CBT plays an important role here, but it's, in our experience, they need a little bit more, particularly around their distress and helping them with their experience of emotions. Often there's more than one behaviour. It's not just gambling. There might be alcohol, there might be drugs, there might be eating difficulties, other ways in which they self-regulate. So other approaches are really important as well with this group. And obviously we'll be thinking about the extent to which the clinics do this versus bringing in other support from the wider health system. The third group is an impulsive group. So people who are highly impulsive, ADHD will sit in here as well. So again, this group don't always benefit from going straight into CBT. They may need support with impulse control in addition to CBT. We're piloting an ADHD specialist pathway within our clinics. It can take a couple of years to get treatment for ADHD on the NHS. And this group are really disadvantaged. They come to us desperate and in desperate straits with their gambling problems. And to tell them, well, you're going to have to wait for 2 years before you have your ADHD, before that stabilizes and settles down your symptoms in order to benefit from our talking therapy, feels to me a disservice to the population. So we're piloting the ADHD pathway in the northern clinics, as well as looking at impulse control interventions in addition to the CBT. Finally, what we've increasingly seen, and I know it's the same for Etta and Becky's clinics, we're seeing more complexity in presentations and people who are not likely to benefit from the talking therapy pathways, or at least not initially. So these definitely need a wider system of care, and we may play a modest role in that. Often it's really for the CMHTs to take the lead on this patient group, and we may just consult to the CMHT with brief interventions and interventions around stimulus control and so on. Or we may have, it's not one group, so we may be able to help them a little bit more in the clinics as well, and help some of them move through our pathways once we've stabilised them and worked on the assessment of risk and stabilising some of the mental health symptoms. So in broad terms, this is the clinical population that we're seeing. It's a diverse population, and it's important that we assess their differing needs, and going forward, we'd like the clinics to offer, highly specialist treatments to address many of these needs. Not all will need partners and colleagues and other services, but as far as possible, under one roof, they can get the specialist care that we need. And it's worth mentioning again the family pathway as well. So we've got a pathway for affected others, which obviously Jim's going to talk a little bit more about, so I won't steal his thunder about the intervention that I know he particularly supports. But we have family therapy as well, to support that, to support the family system as well where that's needed. So yeah, that was just to underscore, really, I suppose, a bit more meat on the actual the nature of the population, the diversity in it, the specialist treatment that's needed at the sharper end, some of the comorbidities that we're having to work with as well, and just the need for a proper evidence-based system of care from early identification all the way through to aftercare with the support of the voluntary sector and peer support. Thanks, James.
Thank you, Matt. That's really, really helpful, and gives us a bit more of a deeper dive into what potentially what you're seeing at the moment as services, and therefore the areas that new clinics obviously would be sort of being supported by. It's important to note that from an NHS England perspective, led by Alex and Etta, there is a clinical reference group that has just recently commenced, and with Matt's work as well, not only from a service perspective, but also, as he mentioned, with the work on the NICE clinical guidelines and other treatment pathway identification and confirmation, if you will, of those sort of treatment pathways is on its way. I mean, Matt, the importance of working with the voluntary sector, not only from the recovery and the relapse point, but also at that earlier intervention space. What's your general view from the clinics that you've been operating in, and how best do you sort of interface with those and gain the support of, or how do you bring in their support as part of your more technical service, if you will, or your more specialist service?
Well, I think we're in a peculiar situation at the moment where there is a degree of flux, in the sense that a statutory levy is on the table, which may have a profound impact on the national system and provide more stable funding, more secure funding, more long-term funding, more substantial funding. So we're all getting on with the job, as it were. So the OHID group and the NICE guidelines will assist the NHS, the National Gambling Treatment Service, have their own consultation in place. But clearly, at some point, everybody's got to come together for a coherent model of care, and it may not be long before we hear about whether a statutory levy is coming into place. So it's perhaps best waiting for that, in that sense. But there's an awful lot that we still need to do. I don't think the NHS has been hugely served by the national system in terms of having a model of identification and referral that makes coherent sense. For us in the north, where we've got such a large geographical area, it's really been a huge job going out across the north to talk to all kinds of different bodies and people, and with the support of comms colleagues, and doing talks from primary care to public health, to local authorities, to so on. There's lots of good gambling projects going on. There's a good one in Manchester, and I think Joe Evans is on the call, who's at the core of the great work that they're doing in Greater Manchester. And I'd advise people to contact Joe if they want to learn a little bit more about how a local and regional system can work for gambling harm. There's a good one in Yorkshire and the Humber as well, and across the northeast. So, but we need a proper evidence-based, connected model that brings everybody together and helps everybody to work closely together. It's still we're still a bit away from that, but the opportunity we've got now with the new clinics, will mean that we'll have to get that right.
Great. Yeah, no, I completely understand, Matt, and wasn't trying to box you into a corner there. I think that's perfectly reasonable, especially, like you say, with geographic challenges as well that you have, and the need for the evidence base has come through very clearly from everyone at this point, and obviously I think what Claire was describing as well is also a helpful, potential connection, not potential, needed connection that is there as well. But thank you, Matt. I really appreciate you taking the time to put some thoughts together and helping us sort of understand clinical populations and treatment areas as well. And I noticed there are some elements going into the chat around the importance of integrating locally as well as strategically, which is always part of the challenge. That's the alchemy that we're all trying to deal with across our work. So thank you so much, Matt. It's been a pleasure to make your acquaintance. And if there are any questions, as you rightly noted, we do have other colleagues on the call. Matt, if you've got any other thoughts that you want to put into the chat as a result of you sort of going through that conversation online just now, would be helpful for us to have some record in the chat, and we can follow those through with links, etc. Really appreciate that. So let's go to Professor Jim Orford, who from Birmingham University, emeritus professor at the university, has extensive experience, knowledge, and academic research backgrounds in gambling-related harm and the impact on affected family members. So Jim, over to you, and thank you so much for your contributions and also for your sort of support for this event. Thank you.
Right, thank you, James. Great pleasure to be here. Thank you very much for inviting me. I want to do three things, basically. One, say a little bit about what it's like to be a family member affected by someone else's gambling. Secondly, to tell you a little bit about the method for helping family members that we've developed in this country. And thirdly, to say a little bit about what role I think affected family members should play in a truly comprehensive service. So if I might have the first slide, please. I've been working away for many years on these sort of issues with colleagues in England to start with, but more recently we've developed that into an international group which we call Addiction and the Family International Network, or AFINET. It's got members now in a number of countries around the world, several hundred members. Anybody who's particularly interested in this, I'd recommend you join it. Membership is free. There's loads of materials, that expand on what I'm going to say now, available there for anybody's members. And it puts people in touch, of course, with lots of other people interested in the subject in this country and in other countries. And there's a strong interest in gambling in this group, I should say. The next slide is just summarizes something about the experiences of family members. We've done a lot of research over the years, talked to, I should think, thousands, we and colleagues, literally thousands of affected family members. And there are three things that stand out really about the stress that family members are under when there's someone in the family. I should say that we call the group we're concerned about affected family members, or AFMs for short. That isn't to rule out people who are affected because they're very close friends, because they're work colleagues, because there are other people who are affected. But we're most concerned with the people who themselves are at risk health-wise because someone close to them has a gambling problem. And we think family members are the predominant group there. And there are three areas that stand out when it comes to gambling. One, obviously, is the financial area. And the financial harm ranges from small things, bits of money going missing, all the way to people suddenly discovering that their home that they thought was totally theirs is actually mortgaged up to the hilt, or that in fact the savings that they thought they could rely on no longer exist because they've been given to gambling operators by a member of their family. So financial stress, large and small. Relationships, obviously, when there's someone in the family who has an addiction problem like gambling, trust is one of the things that is difficult to maintain. We know in the case of gambling that there's a higher risk than average for domestic violence. We know now the importance of coercion in domestic violence, and there's an element when someone in your family has a gambling problem, any addiction problem, including gambling. There's always an element, large or small, of coercion in the relationship. So things happening to the relationship is a big area for family, the stress for family members, and then health, both emotional and physical. That if you're under that degree of stress, you're under that degree of worry about someone in your family, then it's going to affect your health. And we know that family members are highly vulnerable for ill health effects. The next slide really tries to summarize how we understand addiction problems in the family, and in this case, gambling problems in the family. So at the top, we've got gambling addiction in the family has a stressful impact. And at the bottom, we've got that running through to family member strain in the form of ill health for family members, both for adults and for children. So the important thing about this is it's a stress strain model. The way we are understanding, and we'd recommend that other people see gambling in the family, is in terms of it being a very considerable source of stress to everybody. I mean, goodness me, it's stressful to the people who are carrying the problem themselves, the people who are gambling. It's an extremely stressful and unpleasant thing to have, and family members share that stress. It's a peculiar aspect to the stress because they're affected family members, not necessarily the people who are doing the gambling themselves. But it's highly stressful, and this is a stress strain model. And the reason that's important, I think, is because that hasn't always been the way in which addiction and the family have been seen. When I first came into the field, and I was interested in those days in alcohol particularly, when it came to families, it was wives, because it was thought pretty much all to be men who were heavy drinkers, and it was wives. And the predominant view of the family was that wives were somehow implicated in causing their husbands' problems. So over the years, fortunately, stress strain models have given, have overtaken those kind of models, because one of the things that family members often think is that, am I to blame in some sort of way? And one of the most useful things about counselling family members is to somehow get them to see that they are not to blame. So to have a model that sees things into stress is really important. And then in the middle of that are three things that perhaps mediate between the stress and part of it and the strain part of it. And that is lacking information, the information that family members need, the dilemmas about how to cope. No one tells you how to cope with an addiction problem. It's not something we're brought up to think we're going to cope with. It comes on as a surprise to people, and people are at their wits' end as to how to cope. And then thirdly, getting the social support that people need. And I'll say a little bit more about those in a minute. So if I could have the next slide. This is the method for helping family members that we've developed here. We've developed it over quite a period of time, based on the considerable research that was done on what are the experiences for family members. This method has been exported now to a number of other European countries: Germany, the Netherlands, Ireland, and beyond. Australia, New Zealand, India, part of India as well. And it's got these 5 steps to it. And the first, and possibly the single most important, is simply to listen non-judgmentally to what a family member has to say about her or his experiences of living with someone with a gambling or other addiction problem. And then to address the information, the coping, and the support aspects that are so important in our model of what's going on. And I'll say a little bit more about each of those in a minute. And then the 5th step is to review and what's going on and arrange any further help that's necessary. So if I could have the next slide. Just to draw attention to some of the features of this model, we like to think of this model as a particularly flexible first stage model. So we argue that it's applicable whatever the relationship of the family member, or indeed other affected person, to the person with the addiction problem, gambling in this case. It's applicable in a wide variety of settings, including healthcare settings, both primary and specialist. So I was particularly interested to hear what Claire Gerarda had to say about her new gambling service. One of the bits of research that we did was actually trying out the 5-step model in primary care, delivered by GPs, primary care nurses, and health visitors. And I agree absolutely with Claire that not everyone in primary care is going to want to do that kind of work, but we found for that study plenty of people who did. And it can be done outside healthcare settings altogether. So it's flexible in that sense. It can be flexible in the number of meetings. When we do it in a research project, we tend to do it in 5 sessions, 1 session to each of those 5 elements. But it can be done in a much smaller number of settings, concentrating perhaps on the listening and the providing information, if that is all there is time to do. The number of family members attending, usually it's 1, but it may be 2. It may be a father and mother concerned about a son or daughter's gambling. It can be done in the form of a self-help handbook largely, which we used, for example, in Etta's London clinic to very good effect. And we wrote a joint paper on the work that was done there using the 5-step method. it can be extended then to joint work with the person who is the gambling person or the person with another addiction problem, although the 5-step method is for the family members in their own right to start with, but it can lead on to joint work. And this method, we have a system for training people and providing accreditation if people want to go on to do that. And there's obviously more I could say about that, but there's not time to expand today. So if I can go on to the next slide, just to say a little bit more about the information element. Information is very important. People, family members, when there's an addiction problem like gambling, are often struggling to understand and to get information. And the information may be very specific. It may be specific about a particular form of gambling. So people may say, you know, my son says he does online slots, or, you know, what the hell is online slots? Or so there's specific information like that that family members may want to know about. But one of the core things that often comes up is, what is addiction? You know, there seems to be something terrible going on in the family. Families, the relationships are being affected, my health's being affected, and it seems to be because of this inexplicable behavior of someone I love and someone I trusted and someone I'm sharing my life with. So what is gambling addiction? And here's just a couple of people. There's one person who says, I've racked my brains trying to figure out what's in it for him. You know, what is it? And I've tried various solutions and they don't seem to work. Someone else says, it seems like very selfish behavior, this. And then I think about it and I think, is it an addiction? So these are really things that family members need a lot of help with to think through. They really are, you know, almost philosophical dilemmas that family members face. The next slide says something about the coping dilemmas. I mean, this is a very the financial side of it is really a nightmare often for affected family members. And here's a sister who's been approached, you know, by her sister saying, I've got some debts, can you help me out? And she wants to help her sister out, but she's not very happy about it. She talks to their mother, she talks to her husband about it, and she reluctantly decides she's going to give her a loan, but she thinks she ought to put conditions around it. So she says, only if you tell your husband, and only if it's a secure loan. She lends her £5,000. And she says, as she says, I'm not best pleased about it, but she decides that that's the best thing to do. So there's a typical coping dilemma, and family members' lives are filled with major and minor coping dilemmas of this sort. The next slide, please. Right, this is another kind of dilemma. How strict should I be with him? So here's a partner who says, I don't want to mother him, but I feel I'm being pushed in the role of a strict mother. Well, I'm a partner. I don't want to be his mother. That's not what I married him for. So that's another kind of coping dilemma. The next slide is about, and I don't have time to talk about this in any detail, but when it comes on to the social support element, what we do is we use a kind of spider diagram and we talk to someone about all the people who might be helpful. And what tends to come out is that some of those people are helpful. In this case, a mother, her sisters were quite helpful, and a close friend was helpful, but her husband wasn't. She and her husband obviously had different views about how to cope with it, and that wasn't very helpful. A mother-in-law wasn't very helpful. A stepfather wasn't very helpful. So as a result of that, we decided, yeah, why don't you talk to one of your sisters? And she chose one of her sisters, and we did a bit of role play. How are you going to bring this up? You know, because your sister doesn't know everything that's been going on. How are you going to broach this difficult subject? So a bit of role play came into that. So those are kind of some of the things that constitute the five-step method. And then finally, I just want to say, if I can have the next slide, I want to say about what role I think family members should play in a comprehensive service. And really, there are two aspects to this. And the first one is really by far the most important, because we think that only a small minority of people who could benefit from help with their gambling problem are actually in touch with someone who specifically is addressing their gambling problem. So that leaves 90 or 95%. I'm not sure what the figure that people reckon is now, but that leaves at least 90% of family members who are living with someone with a gambling problem, where the person with the gambling problem is not currently getting any specific help for it. So the most important thing that we can do in a comprehensive service for family members is to give them the kind of help that I think the 5-step method is a good first step in that, for family members in their own right. And then, of course, for those where the person they're worried about is in touch with treatment, then we should include them as partners in the treatment, because the evidence is that treatment for the addiction problem, the gambling problem, goes better, has better outcomes if a supportive family member is involved. So there's 2 ways in which this should be done. And then the next slide, I ask myself, having worked in this field for many years, I ask myself why we are not making more progress. You know, why aren't family members at the center of services for gambling, for addiction, for mental health, I should say. It's not just addiction, but you know, family members are much more on the edge of things than they ought to be. And I think there's several reasons. One is they just don't get policy direction from on high. It's not policy that family members should be involved. And then there are all sorts of barriers involved. I just mentioned 2 there that we discovered when we were working with organizations to try and get them to involve family members more. I remember working with one in Birmingham where they had a really awkward recording system, and they said, well, it's very difficult to help family members in their own right because they have to be recorded as patients. And so, you know, this understanding sort of who is a client and who is not a client, and if someone who's only a client because they're worried about someone else, this really makes, you know, some really clumsy recording systems find it very difficult to record them at all. So that was one thing to start with. And then there's this confidentiality thing. And I think people often bring that up and say, well, it's very difficult to work with family members because of confidentiality. Well, that's nonsense, really. I mean, yes, of course, you've got to know what your confidentiality rules are. You've got to know what an individual person is happy for you to talk to a family member about and not. But there's no reason why you can't address the concerns of a family member. I was talking just the other day to someone who was crying. She was crying with anger as much as anything else because she'd phoned up the residential unit, it was, where her son was staying. She was desperately worried about him and told by the person who received her phone call, "I've been told I cannot talk to you." Well, this is a really sort of you know, clumsy and really unhelpful way of using confidentiality, which itself is important, but you can work within confidentiality with family members quite well. And then of course people need the training and they need the experience. So I think my final slide is now, oh well, no, we did a Affinet did a project and we looked at all sorts of documents from several countries, and we found that often family members weren't mentioned, and when they were mentioned, they were often mentioned in a very peripheral way. So just from the policy angle, addiction is not getting into policy documents properly. So this is my final slide, the last one. This is what I want you guys to do. And I want you to do these 4 things. I want you to make sure that right from the top downwards, putting family members at the center, not on the edge, but in the center of a comprehensive service, it's in your policy documents right from the top. There's then got to be leadership, management leadership within the treatment providing services, whether they're health service, whether they're charitable, whatever they are. There needs to be proper training about how to work with family members, and to listening to family members, listening to the experts, experts by experience who can tell you what it's like. And finally, of course, people need to get in there and get practicing and get experience of what it's like to help family members. So that's what I want you guys to do. I leave you with that. I lob that over to you, James.
Well, thank you, Jim. We'll try and catch that with a wicket keeper's touch, and say thank you very much for giving us the insight there. It's really clear that there's been a huge amount of work and research that has been undertaken, and that it's actually applied into services so far, especially through ETA and others. And it does really jump out the importance of both lived experience of family members, as well as those with lived experience, which we'll go on to. But Jim, thank you so much, and thank you for taking the time to speak with us today. We really appreciate it. Thank you. Good. So look, we're sort of coming up to our final section now, and I'm really pleased to sort of following on from that lived experience conversation and family members that we've had. We've got Stacey and Nick on the line. Guys, we've probably got about sort of 8 to 10 minutes each before ETA comes in and gives us a bit of insight. I'd just like to say personally that both Stacey and Nick are hugely inspirational. We'd already touched on it, I think, earlier in the call today, that we talked about the impact and power of lived experience, especially in recovery. Both Stacey and Nick's presence in social media and in the online world is a really helpful insight, really, into trying to understand both individual story, but also how they themselves are trying to help and trying to sort of, contribute to this agenda because of their genuine desire to help and their belief and support in recovery. Their belief in recovery. So, Stacey, over to you. Hello, and I hope it's been a helpful conversation to hear the conversations, and we'd love to hear your take and also your experiences as the girl gambler.
Can I say go and take as much as you want, because I don't really have very much at the end. And I think this is such an important part of the day that we want to do it justice. So, I'm happy to just have a couple of minutes at the end and give you as much time as you need. Thank you. Thanks,
ETA. Thank you. Go ahead, Stacey. Nice to see you.
You too, and thank you for inviting me. It absolutely is it's so heartwarming to see conversations happening around it and people so aware of it. So yeah, my name's Stacey. I started my first job at 18, and it was in a bookies, and I knew nothing about gambling before that, really. That was where I was opened up to the gambling world, and it wasn't that long after I started. I'd always promised myself I would never bet, never go on one of those machines. I saw what it was doing to people, and I was absolutely adamant it wouldn't happen to me. And then one day, me and my friend went over into another shop, and we put £1 in, and I won. And from that pound, my life just turned absolutely upside down. One of the things I noticed kind of really initially was that I kept breaking my own boundaries, in that I'd convinced myself I'd gone from nothing to £1, and then I'd promised myself that I would never put a note in, but I quickly went from putting coins in to putting my first note in, and then I broke a boundary and saying, no, this money is aside for rent or whatever it might be, and again breaking a boundary into going into that money. And I think looking back, that was an important thing for me. My life was absolutely destroyed, and one of the reasons that I use the girl gambler for everything I do is that I was a girl, not only for the fact that I was female, but on my 18th birthday I went in and got a job, and I knew nothing about finances or mortgage. I was just looking to go out with my friends and enjoy my life, really. And so I think that kind of highlights for me more as well the education that I lacked around what could happen or the dangers of what this could lead to, because the day before I turned 18 I wasn't allowed in a bookies, and the next day all of a sudden I was allowed to place bets with what felt like no limits. from there, I just continued to gamble more and more, and I knew that I was embarrassed. I was ashamed of what I was doing. I would move from shop to shop purposely, and I'd time myself in the shops to make sure that it didn't look suspicious until I was a 19-year-old girl going on a bus to the next town to try and hit as many shops as I could. And the embarrassment and the shame kind of overtook, and that's when I found online, and the worst thing I ever did. But I was just a username at that point. Nobody saw what I was doing. They didn't know I was female, which was a huge thing for me, because working in the shop, I never saw any women in there ever. And it just led me to further believe that I was the only woman doing this. And I lost everything. I tried to live on my own, and I very quickly didn't pay my rent because I was gambling, and I had to move out. Simple things that break my heart to think about now. I got a hairdryer for Christmas, and that's what I asked for, so that I could heat myself at home because I had no gas. But I couldn't tell anybody any of these things because I was a gambling addict. Like, this was horrendous. And I think, kind of reflecting on some of the things that people have said in here, the first place I ever reached out was actually to Citizens Advice, because I was really worried about some of the loans that I'd taken out. It wasn't to say that I got a gambling problem. I was worried about my level of debt and being so young. So that was the first place I went, and things just continued to spiral for me. I got in massive amounts of debt, and again, the feeling of loneliness and entrapment, the urges were so strong and I couldn't ignore them. I got to a point where I hated gambling, and I would just do it to feel normal, to stop the urges, not because I even wanted to win any money, but just because I so desperately wanted to get rid of the urges that I was going through, to a point for me where suicide felt like my only option, really. And I made a couple of attempts, and throughout the course of my addiction, I did reach out to some places for help. It took a long time, but I did go. My first place where I kind of admitted that I got a problem was my GP. And at that point, I was told to refer myself for counselling, but not to say that I'd got a gambling addiction, but just to say I got low self-esteem. And that kind of heightened for me that, wow, like, this doesn't happen to women. This is something that is completely unheard of. So I never filled the form in because I felt embarrassed. Sorry. I went to a GA group at the age of, I think I was 22, and I was surrounded by men much older than myself, and so again I never returned, and I kind of stayed on that path of gambling and hiding it. And the stories that you mentioned around affected others, I lied constantly to the people that I loved, and I didn't want to, but to me it wasn't acceptable to tell anybody about what I was going through. And I made a decision after I won a jackpot and I lost it immediately. And it was that point for me that I kind of recognised that no amount of money is going to make this better. So I made the decision that I would either go to prison or I would find a residential rehab. They were my two options. Sorry. And very luckily for me, I found Gordon Moody. It was the first time throughout the whole of my addiction, which was 8 years long, that I'd found another woman or other women that I could speak to, which was huge for me. That's where I felt safe. Bear with me 1 second, I'm so sorry. So yeah, and very luckily I went through the application process and I was accepted. And I remember having a moment kind of where I looked at these two women saying all the things that I'd kept hidden for so many years, and the relief, I just burst out crying. not just to know that I wasn't on my own anymore. And from there, I did have a relapse, which I'm quite honest about, and I worked through it, and I kind of understood why. And from there, I've been absolutely gamble free, which I'm incredibly proud of. And I think the most important thing to me is that we have to deliver hope, because I believed wholeheartedly there was no getting better. I genuinely believe that there was no escape, and it doesn't get better. Once you've got it, that's it, and that's it forever. And that's why I decided to kind of share my story. I wrote my book, and I started a couple of social media channels whereby I just share some tips, share what I went through, to let people know that they aren't on their own, women especially. And it's gone bigger than I ever imagined that it would. I think there's 86,000 people following the journey now, and in the past 3 months alone, I've had over 400 conversations with women and men who've reached out looking for support with the gambling. And as these kind of comments show, just a few of them, it's just the fact that they can speak to somebody who's actually been through it. I remember when I had my GA appointment, the first thing I asked anybody was, have you been through it? And if the answer was no, it was a real barrier for me in trusting them enough to know that they do know what I'm talking about. But my recovery has been brilliant, and the support that other people give me as well in knowing that I was never on my own is unbelievable. It really is. And like I say, the volume of people that come forward has shocked even me. It's unmanageable to a point, but we are, and we're getting groups together which have over 40 members a week now, and it's that element of speaking to someone and realizing I'm not on my own. I think one of the other things that I see a lot, and we've conducted a needs analysis which I'm sure the results will show exactly what I assume that they will, but it's about not only, I kind of use this phrase a lot, but I knew how to live with an addiction. I knew how to lie to people, and I knew how to tell your creditors the right things to get out of paying, and I knew how to avoid debt and all the other things. From being 18, I didn't know how to live without that. I didn't know how to manage my relationships or to manage money or any of the other things. I only knew how to live with an addiction. And so for me, a hugely important thing was learning to live without any of that, without not only the gambling, but without the lying, the immediate compulsion to lie and hide what you're doing, or managing the debt, or finding any kind of resilience. Or it's all those things that I really struggled with. And what I believe on my relapse, it was my dad had suffered a stroke, and it was compulsively that I found something to cope with it. And yeah, that's kind of, I honestly can't believe the volume that come forward. I'm incredibly proud of what we've built. Obviously the work that I choose to do now with the Restart Foundation is just going into all of those things that I said. It's not only stopping gambling, but how do I then deal with the debt? How do I be honest with my partner? How do I then, and going into a space where we can do all that, for me is as important as the treatment itself.
Stacey, thank you. And it is amazing to hear your story of recovery, but also the candid nature of how you sort of characterize where you were and where you are now. I think what's amazing is the fact that you are talking in a language that people understand and that your communities understand, and that is such a crucial factor in all of this. And you should be praised for that, and I think we all need to be listening to the impact and the potential of that in reaching into communities and talking with an authentic voice. So thanks, Stacey, as always. I think it's it's been great to make your acquaintance, and I'd love to have more of a conversation alongside others that are on this call about the power of peer support, the power of leadership, and the power for people to sort of express hope through in your recovery. So thank you, and you go with our best wishes as well. So keep at it, and thank you. So and finally, Nick, who is an inspiration to me as a sort of a slightly old, well, I'm an older white male compared to Nick, but Nick and I have we are close. We've got a good relationship. We come from sort of similar sort of places. And what's really interesting from Nick is the way that he is harnessing social media in so many different ways. And I'm just really pleased that you've given us the opportunity to come and speak, Nick. So if you could go ahead and give us your take on things.
Yeah, thanks for inviting me. I feel a bit like a bit out of place with professors and dames, but here we go. So yeah, look, as you know, James, I'm a recovered addict myself. It was a 12-year, £500,000 addiction. And from that, I tried to raise awareness through the accessible use of humour and entertainment, mainly targeting the demographic that I choose to sort of in reach or help, which is primarily young men between 18 and 34. Now, I don't know if I'm using the phrase correctly, but really what I'm trying to do is help the next generation, or help prevent the next generation in a sort of nudge theory way. So I'll let you be the judge of whether 36 is a young man, but probably not. But young men are often disconnected, and I certainly was, for various reasons, a lot of reasons you've touched upon today anyway. They're struggling with mental health, and they really just want to feel something. So they might not drink as much as the older generation. They might be more body conscious or go to the gym more, but gambling is something they can and do because they perceive it to have less harm. So apologies for a crude analogy, but the Ukraine and Russia thing at the moment is an information war as well. And the way I see it, as say, apologies for the analogy, but we're almost in an information war with the bookies. Now, like it or not, and I obviously don't like it, but accounts like Paddy Power's Twitter are really, really good. They're brilliant. We don't obviously agree with what they're trying to do and stuff, but they're undeniably brilliant. So I'm trying to disrupt really the whole model of Gamblers Anonymous, which for different reasons than Stacey, I also didn't work. Not for me anyway. I'm not, I know it's helped hundreds, thousands of people, but sitting in a room and talking and sharing, and then leaving the room and not being able to talk or discuss what you've discussed is really sort of anti the way I think that young people want to live their life, really. It's just not how young people operate anyway. But within an addiction, to me, that secrecy just reinforces stigma. So I'm trying to sort of present a counter narrative to, the pretty undeniable fact that, if you're a lad, you turn on the radio in the morning, you scroll through Twitter, you're on Instagram, you watch football or any sport, you're being peppered all day to have a bet. So if there can be a counter narrative to that, then that's great. So, because as well as that, then if you, even if you do enter recovery is so much harder in the age of social media, because Paddy Power, through the sort of soft power, they'll post memes about anything, related to gambling or not. It's so much harder to do because they're always there. So if people are flicking through their feeds and then I'm there or Stacey's there, or there's a chap called Harry on Twitter, TikTok too, if people see us free as well as Paddy Power and the like, it's going to help. So I think it's about positive content for me. And obviously, I've not come on to an NHS event to criticise anybody, but for me, health messaging can often be a bit too po-faced or a bit too serious, which obviously isn't to say it shouldn't be because of the topic and the subject. But you know, I am a recovered addict of 12 years, and to confront gambling addiction for me, I just feel like the whole sort of conversation needs to be more current, more relevant, and more humorous, you know, more entertaining. Sticking posters up in surgeries is great, but I am talking about social media. As I say, we need to play and beat the bookies, you know, at their own game. In my experience, and you know, from my sort of background, I work in sales, I'm sporty. A lot of the young men that I speak to and have reached out to me, they're all really competitive. Now, if they see obviously really well-meaning, but you know, really earnest and really sad messaging all the time, they don't want to be that guy. They want to relate to someone who, you know, is positive and is who they are, because, you know, like with Stacey and myself, you know, you never wanted to admit it, even though you knew it. You know, I always remember I knew I was addicted after about 18 months. And it took 12 years to confront it. And partly that, I think, is possibly and I believe it's an illness as well, but partly that is, you know, the medicalization or the sort of victimhood or stigma and stuff, which I think puts people off confronting it, because they're competitive anyway, a lot of the time, which is why they fell into addiction in the first place. And they're too competitive with themselves to even admit they are. So again, going back to the, you know, social media stuff, one of my proudest moments is when a lad reached out. He plays football. I'm in Cornwall. He lived in Lincolnshire, and he reached out and said, look, you know, through the content, through your videos, I was in your changing room, and I said, you know, he had the confidence to tell the whole changing room of the football team that he had a problem. And then by the end of the session, they had all supported him and they'd all registered with CamStop. So it's that kind of sharing, you know, which I think people want to do. So shareable content obviously is what drives social media, and particularly on TikTok. That's how it's got a very sophisticated algorithm, and it's all based on sharing of content and stuff. So people see my content and they will share it. They will send it to their friends, their partners, you know, colleagues. And it could be someone sending it to the partner to say, look, don't you think this is you? Or it could be sending it to their partner, saying, look, this is me. And it's an easier way of, you know, broaching the topic rather than sitting down and, you know, having that conversation, which they may not be ready to do. They could send it in a little text, almost like a meme, to their, you know, boyfriend or girlfriends. And that could be a way to get the conversation flowing. So the figures James has put up there are, that's from the last 3 months. So, you know, 20,000 shares of the video, 7 million views, and that's just in 60 days. So it's clearly the virality of the content shows to me that people do want to talk about it, and they don't want to feel the weight of stigma by feeling they can't talk about it. Now, if you remove the shame and the stigma of talking about the gambling addiction, you will naturally get through to people more, because, you know, whether you like it or not, and, you know, obviously I'm not suggesting it's a good thing in any way, but young people do live their life on social media. Now, the people living their life on social media, you know, like every story we all know, yeah, Instagram's fake, etc. But a lot of the lads having a good time, spending money at the weekends, they're also waking up on Sunday morning crippled with anxiety or depression because they've just lost another, you know, 100 quid, 200 quid, 500 quid gambling. So because gambling makes you an expert liar, the more you can share it to embrace being honest is helpful. So TikTok, for those who don't know, which I appreciate maybe a few, it's exploded in popularity. I think it's been the most downloaded app on Apple since 2020. and my TikTok's about over 25 million views. So it's obviously with no, budget or ad spend, that's reaching more people than, possibly the official NHS campaigns or, whatever else would do in a whole year. And it is mainly young men I reach. 89% of my followers are men. You can't see, to my knowledge, the demographic age ranges on TikTok. But from, just sort of observing the people who contact me, generally it's between 18 and 34. And 89% of the people that follow me or watch my videos are men. And that's the crux of, I think, why it works and why Stacey's stuff works. Like Matt Gaskell mentioned earlier, used the phrase, which is bang on. He said, gambling addicts, we're not a homogenous group. So I know that I can't reach the people that Stacey's reaching. And, to a degree, Stacey can't reach the people I'm reaching either. But that's the point. And again, that is what social media is. Now, the fragmentation of media, the segmentation of content, people have so many options and so many different avenues to consume stuff. We can get messages out which are, and me and Stacey will both know this, like she's, part of the messages earlier. We know we're helping people, and obviously I direct people towards, GAM care, etc. Because that's how my recovery started myself. So I called GAM care. They arranged counselling sessions for me, which were to a point useful. But there was no aftercare, there was no follow-up whatsoever. Nothing, So if I had relapsed a week after my last session, then nobody would have known about that. So I, who am I? I'm just, I'm not a medical professional, so I don't have the answers. But the, the in-reach that my accounts have, hopefully provides some questions.
Yeah, I mean, Nick, I wanted you to be on to sort of be a little bit provocative and, to also show the potential, and you're right to have put those points across that, relapse and recovery from your, previous interactions, what's to say. And I know that there's an awful lot of commitment there from the NHS to do more in that space. And, also the stories that you tell and the way that you tell them are so sort of important and really highlight the need for that in-reach to really go against that sort of, homogeny sort of conversation. And I'm just really grateful that, you're able to bring your story, to do what you do online. And, similarly to Stacey, that you're out there recovering loudly and you want to help people, and that there is such a powerful sort of story there for people in recovery to help others. So thank you, Nick. Thank you, Stacey, Jim, Claire, Matt, and over to you, Etta, just for a couple of moments. And thank you to everyone for their involvement and their engagement. Thank you.
James, I think considering the quality of the last two presentations and the brilliance of the whole day, there is nothing else to say other than to thank you for organising, bringing us all together. Thank you to the admin behind the event, which was really perfectly conducted. And I very much look forward to seeing everyone who has been on this call, either speaking or as a delegate, returning, coming together to exchange ideas at the next one of your events. You've done a beautiful job, and I want to say to everybody, have a good evening, and how great that we were all together today. Bye-bye.
Thanks, Etta. Thank you. Bye, everybody. Thank you so much. It's been great.
Bye. Thank you.